Today I will be talking about DAAs for treating co-infected patients, and actually I will give you a short overview about treating co-infected patients as we do it in Vienna, and probably many other people do it as well. So co-infection is one of the three areas that my group is concentrating on. Basically, this is what you see, the prevalence of hepatitis C in the HIV population. And as you can see, I don't have any data on Russia here in the Euro-SIDA population, but there's about a third of the HIV population is co-infected. And if you look at the patients more in the East, you will see that there's a slightly higher rate of co-infection there than in the West. So it's likely that in your HIV population you will also have a significant number of co-infected patients. Now what's important in HIV-HCV co-infection is that the survival of these patients is much better if they are on antiretroviral treatment as opposed to being untreated, or in the older days when this report was published on not so active antiretroviral treatment. In fact, HIV treatment has become so good that people don't die of HIV anymore in most cases. And for that reason, hepatitis C has become a very important problem now, because many of those patients, the second leading cause is liver-related death in the co-infected population. Now, what you can see is that in patients with co-infection that have a bad immunological status, meaning low CD4 counts, you have faster fibrosis progression and faster progression to portal hypotension. As you can see here on the left-hand panel, upper panel, is that with decreasing CD4 cells, you have an increasing fibrosis progression rate, and there's a decreasing time to cirrhosis. And on the top right-hand panel, you can see that with decreasing CD4 cells, you have an increase in portal pressure. And then in the lower panel, you see the indirect correlation between CD4 cells and fibrosis progression rate, and an increasing time to cirrhosis with increasing CD4 cells. So this is data from our group here, published already in 2010, one of several reports showing that there is a correlation between HIV control and fibrosis progression rate in co-infection. Now, one of the general principles here, Vasily, these are not my slides. This is the old version. Okay, but I'm missing slides then in this one. Okay, one of the problems here is one of the principles is that in co-infected patients, they benefit from early treatment of antiviral treatment because the liver progression is reduced and immune reconstitution and suppression of HIV RNA. And in patients with chronic hepatitis C, ART institution is recommended when the CD4 count drops below 500 per microliter, and stopping ART has been associated with an enhanced risk for AIDS and non-AIDS related events. And that is why people don't want to stop antiretroviral treatment when they treat for hepatitis C. And that's one of the reasons when we talk about DAAs, we have to talk about drug-drug interactions, because they become very important in this population. Now, when you look at the data from the combination treatment trials, this is Apricot, the trial of pegylated interferon alpha-2A plus ribavirin, published in 2004, you can see that patients do much better on this combination treatment, not only in genotype 2 and 3, but in the end of follow-up response is only around 30% in the genotype 1 patients and it's 62% in the genotype 2-3 patients. So it's okay, but it's not fantastic because 70% of the patients don't get healed, especially with genotype 1 infection. Also, when you look at the same data and you look at the genotype 1 patients according to baseline viral load, you will see that this has a profound effect on the cure rates, because patients that have a low viral load, even with genotype 1, still have around a 60% cure rate, while if they have a high viral load, then the cure rate in the co-infected patients is very poor, with 18%. So obviously here in the co-infected patient, viral load plays a more significant role than in the mono-infected group. So in 2012, the AIDS treatment group wrote up some guidelines on the optimal treatment in co-infection. And as you can see here, stratification goes according to HCV RNA at week 4, because if HCV RNA is negative at week 4, meaning that people are rapid virologic responders, then treatment durations is shorter, especially in genotype 2 and 3 patients. They will be treated only for 24 weeks, except if they're serotics. And the other thing is that if HCV RNA is positive at week 4, meaning that they are not rapid virologic responders and they're genotype 1 patients, then extended treatment duration to 72 weeks is actually recommended. So that's what you see here. Those are the two important issues in response-guided therapy with dual combination therapy in co-infection. Now, our group, together with a group from Spain, actually from Professor Pineda, looked at the impact of IL-28B SNP and on the impact of advanced liver fibrosis on response-guided therapy in HIV/HCV co-infected patients. And what we found is that in genotype 2-3 patients, neither IL-28B nor advanced fibrosis really has an important impact, meaning that in those patients, response-guided therapy does not have to be tailored according to the IL-28B or according to advanced fibrosis, because those patients are doing quite well. On the contrary, when we look at the impact of the IL-28B and advanced fibrosis in the genotype 1 patients, especially the ones that have no rapid virologic response, and that is the majority of those patients, then you will see that if you have a non-CC patient on the left-hand panel on the right side, then extending treatment duration to 72 weeks really is very important, because you can almost double your end of follow-up virologic response. And the same is true if you have advanced liver fibrosis or cirrhosis, then, which is on the right-hand panel on the right side, then you can see that you almost quadruple your actually sustained virologic response in those patients. So in those patients, extending the treatment duration with dual therapy seems to be a very important issue in co-infection. More important than it is in mono-infection, I have to say. Now, the other thing that we were interested in, this is another work from our group in Vienna here, is that we wanted to predict SVR by using not only IL-28B, but also IP10 levels. IP10 is an interferon-inducible protein 10 and has been shown to be a predictor for response, meaning that if patients have a low IP10 level, which is an indicator of a low activation of interferon-stimulated genes, then this is good, because then by giving interferon, you're able to mount a stronger immune response by stimulating interferon-stimulated genes. And as you can see here, in this population that comprised of around 70% genotype 1 patients, if you have an IL-28B CC patient plus a patient with low IP10 levels at baseline, then even if those patients are genotype 1 patients, you have an almost 100% chance of cure. So this is a very important predictor of a pretreatment predictor. And then, of course, in those patients that you can see on the right-hand level, you can treat them very well with dual therapy. And in those patients, you will not need triple therapy. While on the other side, if you have a non-CC patient with a high IP10 level, on the left-hand side, then those patients are very unlikely to respond to dual combination therapy, and in those patients, it might be very sensible to treat those patients with triple therapy from the start. Now, but a really important issue is the real-life HCV clearance rates, and that's actually the real-life rates of treatment. This is a work that my group did together with a large group of German practitioners treating co-infected patients. So as you can see, the total number that had been screened was over 9,000 patients in Austria and Germany. And then as you go down, the patients that actually had co-infection and were evaluated for therapy were 915 patients. And then amongst those 915 patients, only 540 were treatment candidates. And of those, only 416 started treatment. And in the end, you had an SVR rate of 41%, but out of the 915 patients that actually were co-infected, only 170 patients had an SVR. So the SVR rate for all treatment candidates was 31%, but the SVR rate of all chronically infected patients was only 16%, due to the fact that many of those patients could not receive treatment because they either did not want treatment or they were not eligible for treatment. So that means even though your treatment might be quite effective in the ones that you can treat, quite a few of those patients you will not be able to treat, and 16% SVR in all of the co-infected patients will mean that quite a few of those patients will have progressive liver disease and will run into problems with their liver disease eventually. This is the same data shown in a pie chart, and it just shows that, of course, alcohol abuse, comorbidity, end-stage liver disease, active intravenous drug abuse, psychiatric diseases are very important obstacles to treatment in the co-infected population. Now, what do the current EACS guidelines for the management of genotype 1 infection say now? Well, they say if you have a newly diagnostic HCV genotype 1 infection and you perform transient elastography or serum markers of liver biopsy, and Laurent will probably talk about that, then if you have an F0 and F1 patient, in general, treatment can be deferred. And the reason for that is that treatment is hard on the patient, might be difficult, and we will have better treatment options in the not-so-distant future. In F2 and F3, you should treat those patients with pegylated interferon ribavirin and probably a protease inhibitor, but I personally would be more conservative on that, to be honest. We only treat F3 patients with triple therapy, and I think in F2 patients there's still enough time to defer treatment until we have better treatments. And in F4 patients, well, usually those, if you can't treat them because they're not decompensated, then you will use triple therapy in those patients because dual therapy really works not well in genotype 1 cirrhotic patients. Now, another way of looking at this is this kind of a diagram where you can see not only according to fibrosis stage, but also according to prior treatment status, that in F0, F1 naive, you take an individual decision. Usually you will defer. In relapses, you will usually defer, and in non-responders, you definitely will defer. In F2 and F3, it's recommended to do triple therapy in naive and in relapsers, and in non-responders, you will defer. But as I said, I personally think that I will use triple therapy only in F3 patients here. And in F4 patients, you will use triple therapy in any case because those patients are really at danger of decompensating and running into problems, except for many of those patients you will not be able to treat because they will suffer severe side effects. Now, the question is, which antiretroviral therapy in co-infection can you use with DAA triple therapy? And as you can see, the two drugs that are available at the moment is boceprevir and telaprevir. And for the two, there's slightly different use of antiviral therapy. The basis of antiviral therapy is usually a nucleosidic reverse transcriptase inhibitor like tenofovir or abacavir, together with a second one, either antricitabine or lamivudine. Plus, then you will add either a protease inhibitor like atazanavir or an integrase inhibitor like raltegravir, or you can add also an NNTR like rilpiravir, entravirine, or efavirenz. And with telaprevir, you have basically the same regimen of a nucleoside reverse transcriptase inhibitor, plus then you can use raltegravir or etravirine here. So those are the options. So you are limited to some extent with the antiretroviral therapy that you can use. Combination therapy with telaprevir for chronic hepatitis C and genotype 1 infection. So up to now, this is the only trial that's published in full, and that was actually published last week or 2 weeks ago as electronic publication in Annals of Internal Medicine. And this is really a fairly small study, as you can see. There were only 62 patients enrolled, and of those, 60 received the drug, and then you had several different groups. In the end, only 58% or 35% of 35 patients completed the treatment. This is really a tiny trial, and 42% of the patients discontinued the drugs due to either virologic failure, due to adverse events, or to other reasons. Now, what you can see here, of course, is that triple therapy, as compared to dual therapy with pegylated interferon and ribavirin, works also in co-infected patients quite well. As you can see here in the dark circles, you have a much more rapid virologic decline in those patients. Actually, within 1 week, a very, very rapid decline. And then most of those patients will be negative by week 2. Definitely by week 4 in the ones that respond. And in the end, the sustained virologic response was over 70% in those patients. So it works, and the side effect profile in the co-infected group is about the same that you would see with triple therapy in the mono-infected group. So it's really not much worse. So except for, as you could see, 42% of the patients dropped out. So the dropout rate from triple therapy in the co-infected group is higher than it is in the dual infection, mono-infected. So this is the only trial that's published in full, but as you can see here, there are several trials planned or ongoing with both drugs that are available at the moment. On the left-hand panel in green, the studies being conducted with telaprevir. At least 4 trials are ongoing, including at the bottom you can see the French trial. And then with boceprevir, you have at least 3 trials ongoing that will be reported in the future. And these are not the only studies or drugs that are being tested. You can see here already drugs that are not available yet, but will be available by next year, are being also tested in the co-infected population. TMC 435, which is cimeprevir, where the phase 3 data have been presented at this year's EASL, the so-called QUEST trial, you can see is being tested in the co-infected patients as well. And some preliminary data of that have been presented at CROI this year in February, looking quite promising with a very good safety profile and also a good efficacy profile in all genotypes except for genotype 3. Then there is the Boehringer Ingelheim compound called faldaprevir, where also interim data have been presented this year as CROI in February. Again, this is only genotype 1 patients, but also showing a very good response and a very good safety profile with this kind of a drug. And then there is a BMS compound that's being tested in co-infection as well. Here is just a diagram of one of those phase 3 studies, INSIGHT trial with telaprevir, where patients are not really randomized, but they get telaprevir plus pegirabivirin for the first 12 weeks, and then according to treatment status, prior treatment status, according to their fibrosis status, and according to their on-treatment virologic response, will either receive pegylated interferon ribavirin for an additional 12 weeks or for an additional 36 weeks. So, to sum it up, in HIV-HCV co-infected patients are at increased risk for rapid fibrosis progression. Antiretroviral therapy is vital to reduce progression of liver disease. Baseline predictors like IL-28B genotype, fibrosis stage, or IP10 levels predict response best in genotype 1 without rapid virologic response. IL-28B CC patients that also have a low IP10 level below 400 picograms per milliliters genotype 1 and genotype 2-3 with rapid virologic response have an excellent response to pegylated interferon ribavirin and don't need triple therapy. I think this can be stated quite certainly. Triple therapy with telaprevir and boceprevir can rather safely be used in HIV-HCV co-infected patients as long as the antiretroviral therapy is tailored to the regimen and adverse events are managed properly. Triple therapy at the moment should be reserved for F4 patients and for F3 patients that are treatment naive and relapsers. All others probably should be deferred until next generation of DNAs are available or until interferon-free regimens are available. And what I think is the biggest challenge today for treating those patients is not which regimen to use, but to get those patients that are suitable for treatment really to treatment as we could show in our data, because if those patients don't get treated at all, there is no chance of cure and progression of liver disease is almost certain. Thank you very much.